So we broadcasting also in the Zoom. Okay, shall we begin? Good afternoon, ladies and gentlemen, professor and doctor. It's my pleasure to welcome you to this wonderful event. Please let me introduce myself. My name is Dr. Ludidiani Rahmartani, a pediatric hematology oncology consultant from Cipto Mangunkusumo National Hospital. And I'm here to be your moderator and also the master of ceremonies. And today I would like to extend my gratitude to Professor Tati and her esteemed team for their invaluable efforts for making this event possible. Professor Tati Suhartati Gonowiharjo is a highly respected professor in radiation oncology who has made significant contribution in cancer field, both nationally and worldwide, particularly for cancer patients in Indonesia. Her impactful work has been felt in very movement she has made. Professor Tati Wiko, thank you for your invaluable contribution for making this event for a great success. Your warm welcome of Professor Stefan and his team was beyond that I could have imagined. Despite meeting them for the first time, you willingly agreed to give your time and support to welcome us. I cannot thank you enough for your generosity and kindness. Thank you so much, Professor Tati. And I also would like to extend my silence gratitude to our distinguished panelists, Dr. Murti Andreas Tuti, specialist anak consultant, our pediatric hematology oncology consultant, Dr. Eka Susanto from pathology anatomy department, and also Dr. Handoko from the pediatric neurology radiation oncology, all in this hospital. And also the esteemed participant and the one and only our exceptional presenter, Professor Stefan Fischer and his team. And we also have Dr. Opot here, Prakash, and also Alexandra and Svenja from Heidelberg. And before we begin, let us honorably welcome the words from our esteemed coordinator of comprehensive care at Cipto Mangunkusumo Hospital and also the chair of tim pengampuan Cipto Mangunkusumo Hospital, Professor Sartati Gonowiharjo, specialist oncology radiation consultant. Please welcome Prof. Tati.
Much, Dr. Ludi. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen, my fellow colleague here at RSCM and other participants online. We saw that there are more than 50 personnel online with us right now. Guten Morgen. Herzlich willkommen. It's my pleasure to welcome everyone this morning, hybrid lecture today. It's a part still of our full month virtual capacity building in our hospital about network of cancer care for World Cancer Day. The 4th of February was is the World Cancer Day, but as well as also the Childhood Cancer Day that will be in 15th of February. So it's a good opportunity to have all of you with us here. We are honored to extend a warm welcome to Professor Dr. Matt Stephen Pfister, who is a global renowned expert in neuro-oncology, and he's here in person with us in RSCM. And you know, from Heidelberg, I was there in 1989, maybe. Since that I was trained in Woodstock. And anyway, thank you for your visiting us in Indonesia with your team. We look forward to gaining valuable insight from your talk. We have our panelists from RSCM today, as it is already mentioned by Dr. Ludi, who will bring forward a live discussion today. Dr. Handoko, radiation oncologist, again, Dr. Murti, the pediatrician, and also Dr. Eka, the pathologist, and Dr. Ludi as the moderator. And thank you for joining us. As you all know, that pediatric cancer is one of the prioritized program of our Ministry of Health. So we have 4 prioritized program right now: cervical, breast, pediatric, and lung cancer. So we hope that we will see a significant advancement in near future in RSCM. And you know that under us, there are something like a system in our countries, so-called the, what is pengampuan in So we divided Indonesia in several area, regional, and Cipto Mangunkusumo has to improve 4 province in terms of the 4 cancer, as I mentioned before, the breast, cervical, lung, as well as pediatric. So your time to come here is very good. So we invite also friends from other province, as I mentioned. Maybe it's difficult to explain to you. One is close to us, Banten. One is in the south of big island, so-called the Sumatra, is in Lampung. And next to Sumatra, there is another big island. We have a lot of islands. We have 17,000 islands. Another island, so-called the Kalimantan, the west one and the south one. That's area that we have to improve them to become a good center to treat cancer. And pediatric cancer is one priority from our government. And so I hope that everyone will make the most this opportunity to engage with you. Hopefully you are eager to do it. And his team, wherever you are here in person or virtually, ask questions, share our case, discuss your thought. It's a very precious opportunity. Thank you again. Vielen Dank für Ihre Besuch. Und ich hoffe, Sie genießen Ihre Aufenthalt in Jakarta.
Very much so.
That's what I can say. Only a small thing of German that I can still. Ich kann nicht auf Deutsch sprechen. Nicht mehr. Vielen Dank.
Very good. Dankeschön, Prof. Thank you, Prof. Sahartati, for your infallible insight and speech. And ladies and gentlemen, as we move forward, I urge you to maintain your focus, please, to this event, because this is a great honor that I introduce esteemed speaker, my Professor Stefan Pfister from Kids Hope Children Cancer Center, and also the German Cancer Research Center. Sorry if I'm get wrong to spell it. And as we know that Professor Pfister has made outstanding contribution to pediatric oncology, and we are privileged to have him with us today. And please allow us to welcome you to the stage. Thank you.
So first of all, thanks very much, Professor Dati, for the very kind introduction. I'm not only impressed with your professional skills, but also with your German language skills. So that's amazing. And also Dr. Ludi. And yeah, first of all, I want to say that we really feel very welcome here. Very many people who have met, who are all welcoming us in a very, very friendly and collegial way. So it's really very nice to be here. And I hope that the topic of my talk today will also be of interest to many of you, especially the ones obviously who are treating pediatric brain tumor patients, but probably also other patients who will eventually benefit from this. I will be talking about brain tumor diagnostics, which in the first place might sound kind of very fancy and very advanced, but I think that this is really something that can be disseminated now across the world, and we are very much looking forward to also trying to help with this. Not yet moving. Here we go. Yeah, so I just want to briefly start by saying that we have already had contacts with Dr. Ludi, but also Dr. Vico over years ago. So it's not kind of a first visit and a first contact now. And this is why I also sincerely hope that we can really establish a long-standing collaboration with your hospital. Because I think that we really, and I will come back to this over and over again, can also really learn from each other a lot. And I just want to start by giving a little bit of an introduction into diagnosing brain tumors and how this has changed over the years. And then in the second part, tell you a little bit about the advanced molecular methods that we have been applying in a routine diagnostic setting in the recent years. And then finally, also talk about how this can probably be disseminated across the world with the Outreach Consortium, which also brought us here today. So basic principles of neuropathologists, then we have the pathologist sitting here, is basically, and has been for many, many years, to basically look at the tumor macroscopically, but also microscopically, and really using the good old microscope to distinguish different tumor types. And in the end, it's always about the same questions. It's about the malignancy grade, then it's trying to assess the prognosis of the patient. And ideally, we also want to learn from the diagnosis what is the best treatment for this patient, right? And in the end, much of what is happening here is basically looking at a process of differentiation. So you're looking at a tissue and you are asking the question, is this a very primitive tissue? Is this highly proliferative tissue? Is this a very anaplastic tissue? Or is this something that is more differentiated? And this largely determines whether a tumor is considered to be rather benign or rather malignant. And this has been the kind of mainstay of diagnostics for brain tumors, not only for brain tumors, but specifically for brain tumors for many, many decades. So I just want to start by some important principles here. So when looking into pediatric brain tumors, and this is just a population, a simulation of a population, but it's actually real data. Then with state-of-the-art treatment, we know, for instance, that low-grade gliomas in children, which are considered WHO grade 1 or WHO grade 3, grade 2, actually are associated with a very good outcome. They can rather be considered as a chronic disease rather than an acute disease. So many of these patients, especially if the tumors cannot be completely operated, need repeated cycles of treatments, but they typically do not die from their disease, but rather are chronic disease patients. If you look into medulloblastoma with state-of-the-art treatment protocols, they have also reached like 75–80% cure rates at 5 years of follow-up in the last decades of optimizing the therapy, consisting of surgery, radiation therapy, and chemotherapy. Whereas, for instance, the high-grade gliomas in children, which are considered WHO grade 3 and 4, actually are still associated, even to the best of our knowledge, with the best therapy, with a very dismal outcome. And at the moment, we really don't have a lot to offer to these patients. So one point that I want to make here is the challenge with WHO grading, because we have the examples here of low-grade gliomas and high-grade gliomas. But for instance, medulloblastoma is also WHO grade 4 tumor by definition. But due to the fact that we have much better treatments available nowadays, it basically has a cure rate of 80%. So when you confront the patients with, saying them, you have a WHO grade 4 tumor, and then they Google it, and they find out it's the deadly disease. But this WHO grade 4 and this WHO grade 4 is quite different in terms of prognosis. So this is why WHO grading, in a sense, is also becoming more a relative term than an absolute term at this stage. when you try to basically categorize all the different tumor types that typically occur in children into the WHO, this is how it would be looking like in the WHO classification of 2016. So you would have a representation of embryonal tissues, glial tumors, ependymormas, other embryonal tumors, and so on. And what you would do at that time is basically looking mainly at the microscopic appearance, doing some immunostains and so on. But nowadays, obviously, this can be complemented by molecular diagnostics. And as you will see from the iteration between the 2016 WHO classification and 2021 WHO classification, a lot have changed, that the diagnosis is no longer purely based on histopathology, but more and more also based on the molecular diagnostics. And I want to basically go through two different parts of molecular diagnostics today and show you and try to convince you that this is really complementary. So it's not one that can replace the other. On the one hand side, DNA methylation analysis, where you're actually measuring chemical substitutions that are covered on the DNA. And obviously the DNA sequencing, which is looking directly in the nucleotide sequence of the tumor DNA. And all of this, and many of these methods are equipped to do that now, can actually be done from regular paraffin blocks. So there's not necessarily a need to have fresh frozen tumor samples to do all of these analyses. And all of these are DNA-based, which is also a very robust tool to use, or a specimen to use, because it's very stable. It can be shipped around and so on. So what can and probably should we do today to try and also utilize this molecular information to establish the best possible diagnosis for patients? So in the end, it's really a collection and putting a puzzle together. On the one hand side, we get the report from the surgeon. So we have the surgeons in the room as well to really understand what the surgeon thinks the tumor is looking like. We have the radiologist who basically can add to this and to say, okay, but on the imaging, this looks like a medulloblastoma, this looks like an ependymoma, it has contrast enhancement, it has edema, it's probably fast growing and so on. It has central necrosis, it has cysts and so on. Then we have the pathology, obviously, and it's not, you know, I'm not trying to imply that we should get rid of conventional pathology. I'm just trying to advertise for the fact that we can add new layers of information by also looking into the biology of each tumor. And only then, and this is the principle that has been introduced in the WHO classification, only then get to an integrated diagnosis when you have all this information collected together and you're very sure what to do. So as I said, until very recently, most of what we have been doing was based on microscopy and imaging. And over the recent years, we managed to also identify new tools to really try and diagnose tumors properly. One of them, and I will talk a lot about this today and also explain why, is methylation-based tumor classification, which is really based on the cell of origin of the tumor. And then we can detect tumor driver genes by doing next-generation sequencing and RNA sequencing. We can also look into the germline because we know that about 10, 12%, maybe more of pediatric cancer patients are really based on cancer predisposition syndromes, so hereditary predisposition to cancer. We can look into the tumor microenvironment, and obviously we can get crazy and also do single cell sequencing and other spatial resolution omics, which I think nobody at this stage is doing as a routine. But I think it's interesting to understand that actually the spatial resolution, and this is what the pathologists always refer to, is actually what they are seeing down the microscope, which typically the molecular tests do not capture well enough. So I think that the fact that this is coming up now as a molecular tool, a molecular microscope, if you wish, as well, is really looping back to also recognize that the orientation within a tissue is really very important. And we can also, and we have started to do this more routinely now, to also try to identify specific drug sensitivities for individual patients by culturing some of the tumor tissue and do drug tests on a patient individual sample. So coming back to DNA methylation analysis, so why do we think that methylation and sequencing are two complementary approaches to assess the biology of the tumor? So methylation is actually one of the hallmarks of the epigenome. And if you just look at DNA, you will basically realize that in principle, all of the cells in our body have the same DNA sequence. But we still have very different tissues in our body. So if you think of different tissues like muscle cells and liver cells, for instance, you will basically realize that the only determination of these tissues or special cell types, even having the same underlying DNA sequence, is actually the epigenome. So chemical modifications of the DNA that are also transmitted from one cell generation to the next, that basically determine whether a cell becomes a muscle cell or a cell becomes a liver cell or a cell becomes a brain cell. And this holds true also for all the different tissues in our body, but also for the cancers. And one of the specific properties of these DNA methylation changes in cancer is that actually the cancer cells pretty much remain a fingerprint of the cell type that they originate from, which makes sense, right? If you are a blood cell and give rise to a tumor, you will memorize, or you will have a memory that you used to be a blood cell. And when you are a brain tumor cell, you know that you have started out as a normal brain cell. And this memory is really kept in these epigenetic methylation-based fingerprints of the cell. So just to understand quickly what we are looking here. So we are talking about these chemical modifications, so the methyl groups that are added to the DNA in certain places of the genome. And let's assume this is one gene and this is one gene. And then you have several sites. They are called CpG sites, so they can be methylated or unmethylated. So one special thing about methylation that happens at these sites is that it's also digital. So it's not a little bit methylated or a lot methylated. It's either methylated or unmethylated typically, which makes it easier to read it out because it's really a bimodal distribution. You only have zeros and ones. If you look at gene expression, for instance, you always have a gradient between 0 and 1. You have everything in between as well. So it's much easier to digitalize this kind of data and to make use of it for tumor classification in a very rigorous way. So let's assume you have 5 different tumors here, tumor A, B, C, D, and E. And they also have different methylation patterns based on where they originate from. So let's assume this is a medulloblastoma and a low-grade glioma and an ependymoma and an ATRT and a high-grade glioma. All of them will have different methylation patterns. And these are basically, so this first site, for instance, is methylated in all the tumors here. The second site is only methylated in tumor B and tumor D, and so on. And what you can do then is basically sort them according to similarity. So tumor B and tumor D look more similar based on their methylation pattern than tumors E compared to tumor D or tumor B. And that's what we call clustering. So you're basically trying to ask an algorithm to cluster your methylation data based on these yes or no answers of certain CpG sites. And one thing that we also realized is that some sites are not really contributive to this. So they are not useful for this kind of separation between brain tumors, obviously, because not all of the genes in the genome are relevant for brain biology. So we basically have to say, as always, every one of us is unique, so every tumor is unique as well. But still, samples from the same tumor type are much more similar in terms of their methylation patterns than samples from another tumor type compared to samples from the same tumor type. And that's what we are actually doing when we cluster them. So basically, these two tumors would basically cluster together in a two-dimensional visualization. And then these three would cluster together because they also have a similar profile. And when we then look into the sequencing data, so this was all based on methylation, but now we are looking at the nucleotide sequence of them and do DNA sequencing of these two tumors and these three tumors. And what we see is that very often in a certain cell type, you also have a certain susceptibility for a specific genetic aberration. So in these samples here, we probably would find a K27 mutation, which is a histone mutation that is very commonly occurring in pediatric high-grade gliomas. In these samples that also look very similar to each other, we would find a gene fusion, let's say, of BRAF, like we have in a low-grade glioma. So just summarizing this part again, because it's key to really understand why we think that it makes sense to look into the methylation data as well as the DNA sequencing data. So in the beginning, you have a normal cell that is the non-malignant brain cell. That is the cellular origin of a tumor to come. And then you have a genetic change in this cell. So for instance, this green one here, let's assume this is a BRAF fusion, which will lead to a low-grade glioma. And then this tumor cell gets daughter cells and they get daughter cells again. They have the same mutation, but also they still maintain the methylation pattern, which is indicated in these red bubbles here, maintain the methylation from the cellular origin, so the unaffected normal brain cell, all the way until all of the tumor cells. And this is what we are actually measuring when we do the methylation analysis in tumors. So before we started to do this as more of a routine diagnostic procedure, we had looked into many, many different brain tumor types and realized that the methylation-based analysis is very useful to distinguish different subgroups within a tumor. So such as we have just discussed about the medulloblastoma, we know that there are 4 larger subtypes that can be distinguished by methylation. And we have known this many years ago. So the first publication on this was coming out 10 years ago, that this is a very robust method to actually subclassify medulloblastoma. But this is also holds true for high-grade gliomas, for low-grade gliomas, for other pediatric and adult brain tumors. And this is basically why we at some stage arrived at the question, if we had a reference cohort of all the different brain tumor types that are existing and then had an individual patient sample, would we be able to ask a bioinformatic algorithm which of these reference classes does the individual patient sample belong to? So similar as with the fingerprint, you have one sample and have a lot of references. You can basically find a match between one individual sample and thousands of reference samples that you have in your database. And that's when we started to basically try to collect all of the different brain tumor types. And when we started this 5 years ago, we basically had molecular data, these methylation fingerprints of like 80 different brain tumor types. Now we know that probably there are around 200 different brain tumor types, which were not reflected in this yet. So this was not the best thing we can do, but at least it was a very good starting point. And then what we have done is we trained an AI algorithm to actually recognize for one particular patient which class it belongs to. And we trained the algorithm by utilizing the most informative methylation sites across the genome to distinguish between all the different tumor classes, to put it into one of them. And then we get a score, which is between 0 and 1, which indicates the likelihood of a certain tumor to belong to one of these classes. So if you get a score of 0.9 to be a group 4 medulloblastoma, it's very likely that this is actually biologically the diagnosis. If you get a score of 0.3 to be a medulloblastoma, you are not so sure. Maybe there is contamination with normal cells, or maybe there is contamination with inflammation, or you have a non-representative sample, or you have sampled necrosis, which is much harder to detect because the DNA is not intact and so on. But by and large, the software is actually telling us not only that this might be a certain tumor type, but also a likelihood or confidence score, how likely it is that this is really true. And the other really, I think, strong part about this is that the algorithm would also admit if it doesn't know. So it would not force it into one of these 80 classes that we had back then, but it would basically admit, I don't know what this is. And then you get a non-classifiable score. And I think that's very important because typically most of the tools that we are currently using, like many people are now using nanostring technology to classify tumors, they're very restricted by the probe set you are using. And so you're always forcing it into a certain diagnosis. And that's obviously not helpful if you want to be unbiased in the first place. When we have when we have developed this algorithm for the first time, then we applied it to like 1,450 consecutive patients that we got from 100 different hospitals from more than 25 countries. And the outcome of this was very astonishing to us. So basically, we found that in about 3/4 of cases, the methylation analysis would exactly confirm what the pathologist has seen down the microscope. In about 12% of cases, the methylation-based classification would lead to a change in diagnosis in accordance with the pathologist. So basically, we would relay the information back to the pathologist, then they look again at the tumor down the microscope and they say, oh, now having this additional information, I will agree with the molecular diagnosis. And only in less than 1%, these were really only 5 or 6 cases in this whole series. Basically, the pathologist would say, this doesn't make any sense to me and I will stick to my original diagnosis. And then we had another 12% of cases, and that was 5 years ago, where the algorithm would say, I don't know this tumor class, either this is non-representative tissue or this is something that is very rare and this is not currently captured in the reference code. And these are very interesting ones because we also have seen, for instance, that these are the cases where many patients have an underlying cancer predisposition syndrome, where probably the DNA methylation profile, even in non-malignant cells, is different from a patient who doesn't have a cancer predisposition syndrome. And then obviously we were also asked whether this is something that only works in Heidelberg. The answer is clearly no. So we basically had 5 reference centers in Europe and North America back then who also have tried this system. So they basically have done the profiling locally and they basically came up with very similar numbers. So again, in 12% of cases, this would basically change the diagnosis in a clinically meaningful way. And only very few of the profiles were considered misleading, where the pathologist said, this doesn't make sense to me, I will stick to my original diagnosis. So this was basically the transition between looking into individual tumor types and then moving on to a system where we have represented all the tumor types that we know of and asked the algorithm which tumor type does this particular sample belong to. And we basically put this tool out on a website so everyone can use it worldwide. And you can just upload the methylation fingerprints and then you get an email with a PDF attachment saying, this is the classification, this is the copy number plot from this tumor and some kind of minimal interpretation. And we kind of did an experiment with our community because we didn't know whether this would be something attractive to people. And we said, you can use this and you will be asked to also ask your patient whether they would agree to share the data with our database to basically improve the algorithm over time. And so far, and that was a few days ago, we have 138,000 uploads of methylation profiles, mostly brain tumors, but also sarcomas and some other diseases. And more than 100,000 of the patients have agreed that we can make use of their data for further fine-tuning the algorithm and further learning about very rare tumor types. So now we basically have around about 100 uploads per day, and we have about 150,000 brain tumor profiles in our database. So even the best pathologist in the world, who is sitting here, basically will have cases where they only see one in a whole lifetime of a very rare entity, a very rare tumor type. So it's not even possible anymore to basically memorize a microscopic image, because you will never see it again, right? So there is no reference because they are so rare. And so we sometimes now have, we can molecularly define brain tumor types that are 1 in 10,000 brain tumors, 1 in 20,000 brain tumors. So it's you have to see 20,000 brain tumor specimens before you see one of those, right? And this is what happened when we put this out on the web. So these are the uploads from the different regions in the world. And as you can see, Indonesia is not on this map yet. So this is basically time to change that. And this is also why we are here. And this is also how we have designed our consortium now in different countries across the world, in Asia, in Africa, and South America, where all these empty spots are on this landscape of users of this method, because we really think that this is something that should be available to all the populations in the different places in the world, and I will come back to this. After we have basically started to utilize this more as a general tool rather than for individual tumor types, we also still had a lot of additional discoveries of new tumor types based on their methylation profile. So if you have now cases that cannot be classified because they are not contained in these 80 different classes that we originally had, you can obviously also do the clustering and identify new islands here and there and look for similarities here. And based on this, and this is just a selection of different publications here, we identified a whole bunch of new tumor types that were never described molecularly. They might have been described morphologically at some stage, but people were still arguing whether they really exist or whether this is only some, some pathologists who can recognize them, or whether they need more kind of concrete description what they are. And now we can basically identify them molecularly and then go back to the pathology. And very often, when the pathologists now look at these serial samples that seem to belong to the same molecular class, they realize that they can also recognize their distinction morphologically. But now it's much easier because they get 10 of them at once and they can look down the microscope and recognize, oh, they are looking really similar and they are looking different from all the other tumor types that I've ever seen. So what we have done next is actually running a clinical trial or clinical registry of all newly diagnosed pediatric brain tumor patients in 3 different countries. So this was done between Germany, Switzerland, and Australia. And what we have done is collecting all of this information for all these patients, but also do the DNA methylation analysis and a gene panel sequencing on the tumor and on the blood of these patients, and then try to see what we get. So these are the countries that participated. As you can see, it's a lot of different centers. It's a lot of logistics that is involved. And we have collected 1,200 cases prospectively in this series of patients. And we did the pathology examination and the molecular information completely blinded. So the pathologist would not know the results of the molecular testing and vice versa. And whenever there was a discrepancy between what the pathologist has decided to diagnose and what the molecular data would have suggested to diagnose, this would basically trigger a case discussion in a molecular tumor board. And Dominic, who was actually running his study, was really surprised about some of the results. So one of the most striking differences that we found, and this is especially true for pediatric patients, not so much for adult patients, is the distinction between high-grade gliomas and low-grade gliomas. And just remember when we saw this first survival curve, so low-grade glioma patients typically have a very good survival of chronic disease, and high-grade glioma patients have a very bad survival, and we don't really know what to offer them in terms of treatment. However, a significant proportion of what histologically looks like a high-grade glioma, because it's proliferative, because it looks aggressive, actually molecularly turns out to be low-grade glioma. And then obviously the question is, who is right? I mean, if the pathologist says this is clearly a high-grade glioma, and I'm the pediatric oncologist who has to treat the patient, I have to decide whether I want to, give a very aggressive treatment or whether I'm kind of, okay, this looks low-grade molecularly, let's not overtreat the patient. So what we saw in the survival data of these patients is that if you have a WHO grade 3, you're doing better than WHO grade 4. This is what you expect, right? You also can see that these WHO grade 4 patients, based on histology, still have a survival of like 30%, which is very high for what we would call a high-grade glioma. So this is already giving you some indication that this might be a mix of actually high-grade and low-grade. And if you then go to the molecular data, we see patients that would be diagnosed molecularly as pilocytic astrocytoma, so WHO grade 1, which have a BRAF fusion, all the hallmark features molecularly of a low-grade glioma. And we would have patients in this red curve who have a histone mutation and a typical molecular appearance of a high-grade glioma. And they also have the survival that you would expect from these patients. So these patients were all treated as if they had a glioblastoma. So maybe they wouldn't have needed any treatment post-surgery at all. And they were all surprised, and the families, fortunately, that these patients are long-term survivors of a high-grade glioma, but probably they never had a high-grade glioma, but rather a low-grade glioma that looked like a high-grade glioma down the microscope. So if you just break it into these categories, you would basically have this population of patients, and they are like 25% in this series or so of all high-grade glioma patients that you probably would just operate on and then watch and wait. And then you have this, for instance, this very high-risk group where you would try to give most aggressive treatment to try and somehow rescue them. I just want to very quickly mention this does not only work for brain tumors, because the cellular origin and the methylation fingerprint, I showed you the muscle and liver example, it's not really specific to brain tumors. We just started in brain tumors because we were interested in studying brain tumors, but this could also be applied in any other cancer. One of the most interesting applications that we are currently using quite commonly is actually primers of unknown origin or brain metastases of unknown primary. So where you basically have a tumor in the brain, nobody knows where it came from because you don't know the primary tumor. And you can very easily basically predict this is coming from a lung tumor, this is coming from a prostate tumor, this is coming from whatever colon. So this is one of the interesting applications. We have also seen, for instance, that there is an interesting overlap between cervical cancer and endometrial cancer, where you basically, it turns out that molecularly, there are about 10% swaps between what is called endometrial and what is called cervical by the person who is taking the biopsy. And they get very different treatment. So this is also very relevant information to have, just as another application of it. And when, in addition to this DNA methylation analysis, we are also doing the sequencing analysis. In this case, it's a panel of like 130 genes that are specific to brain tumors. So we can find these kind of things like base exchanges in the DNA sequencing. In this case, as an example, a BRAF mutation that we have drugs available now that can target them on NTRK fusion, which basically affected about 15% of this cohort. And then we also did the sequencing of the blood from these patients, and we basically found cancer evidence for cancer predisposition in about 10% of cases, which obviously also comes with the family testing and not only affecting the individual patient, but sometimes even entire families. So one of the striking or interesting results here, which was surprising to us at least, was that again, in these high-grade glioma patients, we found about almost 20% to be associated with cancer predisposition, which I think is quite unexpected. This was never reported at such a high frequency in the literature before. And one of the other things, and this is just an example here, but I think it's interesting to understand that, is that very distinct molecular subgroups of high-grade gliomas have a very high association with some cancer predisposition. So sometimes even by the molecular diagnosis of the tumor, you can conclude that this is a patient who needs to go to human genetic counseling because there is a very high likelihood of this to be associated with an yet undetected cancer predisposition syndrome. So the question is, in the end, who cares about all of this? On the one hand side, the WHO cares, because both in this 2016 edition, but even more in the 2021 edition, a lot of change has been introduced in the WHO classification for CNS tumors, but also for pediatric tumors, to move from purely histology-based definitions of tumor types to mostly molecularly defined definitions of tumor types, which also affects every one of you here, because your pathologists and your diagnosticians are also bound to the WHO classification. So you have to think of how you can basically try to adhere to that, or to basically get up to speed with this. In Germany, we are very happy about the fact that also our health insurances care, because now, for the first time in 2020, they basically have started to reimburse these tests for government-insured or publicly insured patients. And obviously the community cares. And again, this is why we are here now, because we also owe the respect to the community and all of you to basically disseminate this technology and this expertise worldwide. And this is why Dominic has started an international registry where we are also trying to collect clinical information for these many, many cases that are now being uploaded to our website. And Olfat is actually here with us. She is coordinating the outreach consortium that is basically covering a lot of the countries that currently do not have access to DNA methylation-based classification. We got a lot of support from different sites to do that. And I just want to basically show you or mention here that I don't think that this is a unilateral learning, right? It's not that you are learning from us. We are learning from you at the same time and at the same speed. And I just want to show some real data here, which is basically the availability of cancer genome data from different populations. So about 91% of all of the cancer genome data that are in the literature are actually from European and North American population. And if you look at the world population, these are 16.6% of the world's population. So basically in this data set, we are largely missing out 84% of the world's population. So I think there's a lot that we need to learn about these as well, because most likely the diseases that are happening here and the frequency of diseases are different from Europe and North America, because you have a different genetic background. So that's equally important for the community to learn. It's not only a transfer in one direction by any means. So just a few examples of this. The age populations in low and middle income countries in comparison to G7 countries are completely different. Yeah, we have a lot of countries that we are working with now that have a very high rate of consanguinity, where we have a lot of patients who have cancer predisposition because of the consanguinity. We have discussed a lot with our friends in Brazil recently about specific founder mutations that are only running in certain areas. So they have, for instance, P53 founder mutations, they have dicer founder mutations who are associated with a very high rate of cancer at young age, which almost never happens in Europe and North America. So we would not be able to study those by any means. So this is basically how it all started. And we are now, we have gone through a very long process to basically align with all of these participating partners here. And we are very happy that we can basically, we are very close to signing a consortium agreement now, have 12 countries involved now on 4 continents. And we think that this will really be a unique opportunity to grow together even further as a community. And we have started out by inviting the different labs to Heidelberg for wet lab and also for bioinformatics training to get the methylation analysis done locally. So it's not, you know, sending samples from here to Germany, but it's rather doing the analysis here, then uploading the data to the website and get your result back. So it's really meant to enable the local sites to make use of it rather than sending stuff away. So this is the principle, and we hope that this will hopefully work. We also have a steering committee representing all of the different regions in the world. And I just want to finish off, since I know that you're also interested in nanopore sequencing. One of the things that we are currently also trying to do is to adopt this method to be able to be run on a nanopore device, which has 2 advantages. One of them is that the investment costs are much lower than for the Illumina. But the other one is that it can be much quicker. So we now have the first prototype of a device or of a test that actually can be run in 30 or 45 minutes to detect the methylation analysis. And then based on the methylation analysis, you are selecting the genes that are sequenced that are relevant for this tumor type. So if you basically do the methylation analysis in the first 15 minutes of the test, then let's say this is a low-grade glioma, then the algorithm would know that it would only sequence BRAF and FGFR1 and the genes that are relevant to low-grade gliomas. And this is now for the first time that we can use this for the frozen section, because this can be done while the patient is still in the operation room. So this is our hope. This is not ready for clinical application, also not in our place, but I think it's not so far away. So it's probably very few years down the line that we can routinely use that for the frozen sections. And I think that this will be a major advance as well, also for the surgeons, because then they don't have to guess that they are operating a medulloblastoma or pilocytic astrocytoma or ependymoma. They basically can know. And for instance, one of the things that is very difficult to assess is if you, let's say if you have a medulloblastoma in comparison to an ependymoma, for the ependymoma, you have to take more risk for radicality, because you know that they will grow back and they are only sensitive to radiotherapy, but not so much to chemotherapy. For medulloblastoma, you don't need to basically scrape all the residual tumor from the brainstem, because we know that they are radiation sensitive and they are chemosensitive. So you don't have to have a complete microscopic resection for the patient to really have a curative treatment option. We also have started, and this we did through a spin-off company, and this is whenever you read this Epignostics, you know what that is. So basically we have generated a spin-off company to also generate a diagnostic version of this software. So the idea here is that we get CE marking in Europe and FDA approval for this to be used in a diagnostic setting rather than in a research setting. It's currently still a research tool by that definition. And I just want to finish off by a patient from here, one of the first patients that we utilized the methylation analysis to basically learn more. And this very cute girl that I could also meet on Friday, actually the question was whether the differential diagnosis between a glioblastoma and a supratentorial ependymoma. And this is what the methylation result looks like. So basically you get a very good score, even 1.0. That's really rare that you get 1.0. You typically get 0.9 something. for a YAP1 fusion positive supratentorial epineumonoma. And if you compare the survival likelihood of these patients, so if you look into this, this is a French study published a few years ago. The red ones here are the YAP fusion positive epineumomas, PFS and OS. So they have a very good survival. And this is what you expect when you diagnose a glioblastoma. So this is a really important information to have for the patient. It's not only for the treatment decision, but it's also for the prognostication. This is really important. So it was very nice to basically also meet in person this family and talk to them about this experience. With this, I'll stop and summarize and hope that I could convince you that these DNA methylation fingerprints really are a very helpful tool to classify tumors accurately. We are seeing that they are becoming part of the toolbox of a pathologist. So it's, again, it's not meaning to replace the expertise of the pathology, but rather to have an additional layer of information that can help to improve the accuracy in the diagnostic process. We see that certainly more than 10% of cases, even with very experienced neuropathologists, basically lead to a reclassification in a clinically meaningful way, meaning that the patient would get a different treatment after this additional test. Additionally, in about 25% of additional patients, we find the molecular can increase the granularity of the diagnosis, such as in her case, medulloblastoma group 4 or group 3 or whatever. So this is one example for that. And we still have many more of these very small islands where we have like 8 cases, 10 cases out of 150,000 that group together by methylation that have very unusual clinical features, morphological features that we are currently looking into. So these might be very rare brain tumor types that are just not being recognized so far. One of the interesting things is that we very often have a very close correlation between a distinct methylation group and distinct genetic aberrations, which makes sense because you would say that a certain cell type is only susceptible to certain genetic hits. Kind of, if you are a blood cell, you only become a malignant tumor upon certain genetic hits. If you are a certain brain cell, you also only become a malignant tumor if you have a specific genetic hit that gives a survival advantage to this particular cell type. We see that especially in the pediatric high-grade gliomas with this low-grade profile, we think that they basically survive despite therapy and not because of therapy. So these patients really deserve to get a therapy de-intensification. And I mean, everyone is always talking about costs. I cannot compare in Indonesia, but I know that in our system, the molecular diagnostics, the costs for the molecular diagnostics comprise about 2% of a modern cancer therapy. So I think it's worthwhile, this investment. Because if you are doing the wrong treatment, then the costs will be much higher. And obviously the benefit to the patient will be much lower because you're not treating them in the optimal way. So with this, I want to just show all of the groups that have contributed to this, our division in Heidelberg, but also David Jones's division, who is our neighboring division, who is involved a lot in this, our clinical trial unit, also our neuropathology colleagues. So we have always developed this together with our neuropathologists, which was very helpful because it's always really very important to have their expertise on board with this. A very large collection of collaborators and actually a lot of collaborators around the world. So these are all the sites that we have published together over the last 10 years. So you can see that, again, there's a strong enrichment in Europe and North America, and we want to overcome this, but we are also reaching out to many other places in the world, and we hope that we will also have the first few publications together with you guys in the very near future. With this, I want to thank again Dr. Ludi and the team for welcoming us so friendly, and we had a lot of nice experiences together, not only here in Jakarta in the last few days, but also when some of you were visiting us in Heidelberg in the last year. And we are always very happy to welcome any one of you in Heidelberg when you are interested to come. At this time of the year, it's better to stay in Indonesia because the weather is so much nicer than in Heidelberg. But there is also summer in Heidelberg, and sometimes maybe for you, winter and snow is something really exciting. So you can decide whenever you want to come. And thanks a lot for your listening, and also maybe we have some time for questions. Sure.
Ladies and gentlemen, thank you so much, Professor Stefan, for your presentation. Very great and very open our mind to have a collaboration with you. And also, before we continue to the discussion, I just want to add one more example of our patient who already have a benefit of the methylation. I would like to invite Dr. Yudi to present the case. Thank you.
Thank you, Dr. Rudy. Thank you, everyone. Thank you, Prof. Tati and Prof. Stefan, for this opportunity to present our case from our hospital, Cipto Mangunkusumo Hospital. Maybe slide, please. Thank you. This is our case. This is our case MDW girls 4 years, 4 months old and with body weight 16 kilograms. Chief complaint to our hospital with severe headache since 2 months before admission. And she got seizure at that admission actually. And the past illness history, severe headache since 2 months before admission and seizures 3 times a day on 3 days on admission, and a seizure only on at both head and foot, squinting and with duration below 1 minute. There was no fever on or projectile vomit in this patient, and the patient was third children from the third child from 3 children. Family history, there was no family history with the same disease, and the physical examination, she got microcephaly, nystagmus, and increased pathological reflex, and Babinski is positive. Laboratory result to our hospital at 7 February 2024 within normal unit, and at the first time we diagnosed this patient with beta HCG is negative and IFP negative, and already got lumbar puncture also. The lumbar puncture is also negative. And with brain contrast, a brain MRI contrast at 16 February 2022, and I will explain later. And then she got biopsy at 10 November 2022. The result with pediatric glioma tends to diffuse midline glioma minimal CNS WHO grade 2. And we diagnosed this patient with pilocytic astrocytoma infratentorial CNSW at WHO grade 2 and post-op subtotal removal tumor and VP-shunt. At this time, the patient already got a protocol chemotherapy with SIOP LGG 2004. Next. Okay. This is the radiology MRI brain contrast 25 October 22 with the result heterogeneous solid mass with cystic and calcified components in the infratentorial, midline with extension to left the foramen lusca. I'm sorry, the differential diagnosis is that not the conclusion of this result, with measuring 4.3 times 4.3 times 4.8 centimeter, causing tonsillar herniation and obstructive hydrocephalus with interstitial edema in the lateral bilateral cerebral hemisphere. And this is the MRI 25 October 2022. The result in this picture is a solid cystic lesion with post-contrast enhancements in posterior fossa causing herniation of tonsillar cerebratus canal spinalis. And this is the ADC, DWI, contrast, and T2, T1, and flare. The result is it shows solid cystic lesion with relatively restricted diffusion. And this is the next slide. It shows small calcification in the intratumor, the black one. And then the patient got removal tumor, and this is the CT scan after removal tumor at 11 November 2022. With this CT scan show the post-operation show minimal enhancements. The patient already got surgery 4 times at November 9, 2022 with trepanation, removal tumor, and VP shunt. At December 7, 2022, got tracheostomy, and December 23rd, 2022, the VP shunt got infection and absent with EVD procedure, and then January 2023, the VP shunt conversion again. So after the EVD, the patient got VP shunt conversion again. The pathological anatomy result at that time, the histology picture is more in line with pediatric glioma, leading to a diffuse midline glioma, minimal CNS, WHO grade 2. And from our pathology anatomy department, to confirm the diagnosis, biomolecular examination is needed. And then we send to check the biomolecular result, and then the result is methylation class pilocytic astrocytoma infratentorial indication for KIAA 1559 BRAF vision RNA sequencing will follow, and integrated diagnosis from diffuse midline glioma come to pilocytic astrocytoma WHO grade 1. And this is the methylation profiling report. And until the MC pilocytic astrocytoma infratentorial. And at that time, and this time, the patient already got chemotherapy with SIOP LGG 2004 with vincristine, carboplatin, and vincristine for 6 cycles. And the patient plan to get MRI again at December 2023 and still in good condition. And actually at Friday already meet with Prof. Stephen, and I think that's why we need methylation or biomolecular diagnosis to get confirm the precision of diagnosis from pathological anatomy. I think that's all. Thank you.
Thank you so much, Dr. Yudi, for the great case presentation. Maybe now I would like to open the discussion. Maybe for the first, I would like to invite our panelists, Dr. Eka, Dr. Handoko, and also Dr. Murthy, to join the discussion. Maybe sit down here, and Stefan will also have an input to this case example of our case in our hospital. So this is not theoretically, or we don't need to learn from another country. This is our patient. Maybe Dr. Eka.
Yeah, thank you, Dr. Ludi. Yeah, I remember this patient. Histologically, in pathology, we see the morphology of the tumor, and I remember this tumor. Do we have the picture? No. Oh yeah. So I just tell everyone. So histologically, the tumor is moderately cellular, and then one of the differential diagnosis is pilocytic astrocytoma, but usually for the criteria, usually we found many of rosenthal fibers, and we didn't find any rosenthal fiber on the specimen. So I think Professor Fisher, maybe you already know from the tumor board, maybe Professor Andre and Dr. Kapper and Felix Sam already tell about the difficulty and the limitation in morphology. So that happened in this patient. So morphologically, we know that this is a low-grade pediatric glioma, but we further cannot know the type of the tumor is. And maybe this is a good example that molecular tests can provide important and useful information to go to the definitive diagnosis and for the treatment, maybe from the pathology. Thank you.
Thank you, Dr. Eka. Maybe Prof. Stefan have any comment for?
I think it's just illustrating very well that this is not, not a lack of experience. It's basically sometimes that the diagnostic criteria that you need to diagnose a certain tumor type are not met. So then you can also not make the diagnosis based on the microscopy. And that's one of the examples that you are showing here. And the same holds true for some of the immunostains, like, if certain immunostains are negative or positive, this is excluding a certain diagnosis, but it could still be wrong, right? You can still have negativity for GFAP, and still you have a glioma, and these kind of things can be very complicated. And the Rosenthal fibers that you're mentioning are one of these examples, right? That this was always a criterion in the WHO classification. You cannot diagnose a pilocytic astrocytoma unless you have seen Rosenthal fibers. And if they are not there in your specimen or in your biopsy, then you cannot make the diagnosis. It's very simple. Well, now it's basically based on molecular. So you basically can diagnose a pilocytic astrocytoma if you have a BRAF fusion, because the BRAF fusions almost never happen outside of pilocytic astrocytoma.
Yes, this is the one that maybe needs to be clear that with this kind of advanced diagnostic, we can also enhance our diagnostic and also have a right treatment for the patients. Yeah.
It was new to me to know that you are already utilizing the methylation testing, so I'm quite impressed for that. I was just asking that you're already now conducting it in the laboratory of the university hospital?
Not yet. I just sent it to them.
Oh, okay. Yeah.
They have consult the specimen to Heidelberg.
For like selected patients. That
Yes.
yeah. But we'll soon start having it here.
Oh,
yeah.
Of course, that's why I invite everyone here to know about the methylation, and not only some of us who knows this, but everyone who can know well informed about this methylation, and maybe we can like have a good collaboration between us. So yes.
Yeah, thank you so much.
Thank you. Thank you. And maybe the second one for panelists, I want to invite Dr. Murthy for giving us the comment. Thank you.
Okay, thank you, Dr. Ludi. We are very fortunate here, Prof. Stefan, to have you here. And it's very good, very inspiring, your presentation, and very high sophisticated for us. But as a clinician, you also learn a lot about the basic science that it's very helpful to treat the patient. But sometimes as a clinician, we just look the patient from the symptoms, signs, and then the treatment. We collaborate with the colleague from pathologists and from radiologists, but you know a lot about that basic science, and that is very helpful for the treatment for the patient. From the case illustration that we learned, the symptoms is from the patient is already the patient already have a severe headache for 2 months, right? But I think this is a delay diagnosis from maybe from the general doctors, or I thought they already send the child to the hospital or to the clinic, but we lack the symptoms. So the delay, the patient came to after the patient got the seizure. So yes, that's our problem, not only for brain tumor, but for the cancer disease. That's I mean, how can we? That's still our concern to have to educate the doctors how to know about recognize about the early symptoms of the cancer disease, including the brain tumor. And usually the patient with the symptoms like a headache and then seizure came to the neurologist, and then yes, after they came to the like a tertiary hospital that we have subspecialties, and then we can collaborate together. But that's the problem. Besides the recognize the early signs and symptoms, and then if we know about this is possible cancer, the other problem is about the transportation, the economic, that the patient, it's difficult to go to the center of oncology center. Yes, this I think this we hope that we can further make a further collaboration, Prof. Stefan and the team. So what Dr. Ludi have done and the team with this patient, also with other patient that need the further examination, like for molecular testing, still has the chance to get the accurate diagnosis. So that you mentioned that the accurate diagnosis is very important, so we can treat the patient. It's with the diagnosis that we didn't change like this is the pathologist result is different like that. So maybe I want to ask further about the EI, Prof. Now for the radiologists, for pathologists, many centers already use EI for the doctor, and then like you said that not reduce the the capability of the doctor, but this is about to help to make an more accurate. But if you found that the different result between the medical doctor and the EI result, what do you do to to make a diagnosis if you find that problems like that? Thank you.
Yeah, that's obviously a very important question. Also, how to validate it, right? How to validate that why would you believe the AI and not the expert? And this is what we have tried to do with this prospective study, right? That you basically have, let's say, these patients who were originally diagnosed with a high-grade glioma, that you basically see on follow-up that they have a very good survival if they are molecularly a low-grade glioma. So that argues in favor that the molecular diagnosis is correct. But there is additional orthogonal validation of this. So in your case, we just had the example of the ERA fusion. So if you basically have the methylation prediction of this being a low-grade glioma or polycytic astrocytoma, plus you can detect the BRAF fusion as the prototypic hallmark of a pilocytic astrocytoma. Now you have 2 layers of evidence that this is correct. And you have the clinical follow-up that basically argues in favor of that. So this is, I think, how we have to validate it. So if you were taking a radiology-based approach, it's the same thing, right? If you have a, let's say you would use AI to assess metastatic state in a medulloblastoma patient, you would have to basically show that these patients who are diagnosed as M0 have a better prognosis than the patients who are diagnosed with M+ disease, for instance. And so I think that we always have to validate these approaches in a prospective and population-based way. So we also try to basically capture all of the patients in the population. So in our study, we had 80% of all newly diagnosed patients from Germany, from 60 different treatment centers, included in the study to make sure that it's representative. So this is a very tough process to go through.
The delay of the recognize the early symptoms.
So there are 2 answers to that. One of them is that obviously this is happening all over the place. I think it's not a specific challenge in here. But on the other hand, it's true that you can have even further delays in the diagnosis, that you are starting with metastatic tumors, very big tumors, and then you have this additional problem of relocating patients to tertiary care centers, which I think is more severe here. I think that they have run a very interesting project in the UK. I'm not sure whether you have heard about it. It's called Smart Brain. No, Head Smart. Basically, where they try to educate all of the general pediatrician to basically more carefully watch for symptoms of a brain tumor. Because obviously, if you are a general pediatrician, you cannot send every patient with a headache to get an MRI. But there are additional symptoms that come with the headache, typically when you have a brain tumor, right? And this, they could show that this reduced the diagnostic delay for brain tumor patients in the UK by several weeks on average, which was quite successful. But the other answer to it is that we have very good evidence now from the molecular analysis that most of these tumors are actually, even medulloblastomas, which we think are growing very aggressively and very quickly, probably are already there at the time of birth. So it's just the symptoms that occur very late, but the tumor as such, or at least the pre-malignant lesion, is occurring many, many years before we diagnose them. So I think in a way, it's also, looking at a very small period of time. So if we are complaining that it took 2 months for them to be referred, maybe they had their tumor for 10 years before, right? While we have looked into medulloblastoma now and neuroblastoma, it's very similar. So for medulloblastoma, the prediction would be that about 75% of medulloblastomas in children are already present as a pre-malignant clone at the time of birth.
Okay, thank you so much. So I would like to invite our third panelist, Dr. Handoko.
Okay, thank you, Dr. Rudy. Thank you, Prof. Stefan. So what you have presented is very interesting. I mean, that will be the future how we treat cancers, not just in brain tumor, but ultimately in all kind of cancers. And actually, last around 4 to 5 months ago, in the August last year, we have one machine, nanopore. The promethean that is already here. We have run the property. It's not from brain tumor sample, but from nasopharyngeal cancer sample. We do whole genome and epigenome sequencing, and we got the all the methylation data. That I think that thing can fit in what you presented, a website. So I suppose the methylation data from the sequencing, we upload it there, and then you will somehow run the bioinformatics and give us the result.
Yeah, so the current version of the website is not is only taking Illumina data. But we have now developed a version of it, which basically can also handle whole genome bisulfite sequencing from 5, 6 different methodologies. And I mean, obviously, if you are, if you are starting with whatever nasopharyngeal cancer, we don't have a reference data set for that at this stage. But in principle, it works. And if you want to also do that for brain tumors, this is something that then it's also something that you can adopt. And I mean, maybe it would also be worthwhile to connect with Felix Sam or neuropathologists who are basically developing this nanopore assay to basically see whether then you can also adopt this here for the brain tumor.
Yeah. So I'm thinking you are running with Illumina chipset, right? So it is assessing 900,000 positions.
Yes.
And then we can take that regions and then chipset region, and then with nanopore we get everything.
Exactly.
And then we filter it exactly the same region.
Yeah.
And then I mean, so the initial data will be comparable.
Yeah. No, this is now up and running. So it's just not published on the website yet, but we have a classifier version that works also with other data types like the nanopore or whole genome bisulfite sequencing.
And actually, let's say the website that you showed, what kind of data we upload? What I can show you our methylation data. It is something like this. So is it in this kind of format of data? Or
so basically the current format is the IDAT file that comes out of the Illumina analysis. But now this kind of format is what we want to replace it with now that we can also use other.
So it's more generic.
Yes.
Yeah. And then I think how obviously for like if I'm doing nasopharyngeal cancer is no reference database yet. How you do it until up to this point, so you know if this is the methylation profile, this pattern, it is now considered like phylocytic or what. I mean, you collect a lot of patients and then you gather the clinical information, and what is the ground truth? How you know this this patient is phylocytic, the way you develop that database?
Yeah, so what we have done in the beginning is to collect enough cases of that where everyone was sure that this was a certain diagnosis. And then we did the molecular analysis and all the ones that also clustered together as one group and had been confirmed by several experts to be the right diagnosis, they were put into the reference cohort. So if you want to come up with a nasopharyngeal classifier, if you wish, then you would basically have to collect samples from all of the different tumor types that originate in this compartment, and then basically define the groups, and then you train the algorithm based on the known reference groups, which are the different categories that they can select from. And we have basically now increased the reference cohort from initially 80 different entities. Now it's about 180, where we are sure that these are the correct groups based on the clinical features, based on the histomorphology, based on the radiology, and based on the molecular data. And then now we can use them as the larger reference cohort. And the current reference cohort is more than 3,000 samples covering 180 different tumor types.
How do you, when you do the biopsy and then you extract the DNA, you sequence it, whatever machine you're using, and then you profile the data, and then you compare with your database. How about normal brain tumor contamination?
Yeah, so this is obviously this is an important role of the pathologist. So basically, we when we do DNA extraction from tissue, we always take a representative region which is marked by the pathologist to basically do the best we can do. But still, we can have contamination with normal brain, but also inflammatory cells. It's not uncommon. And then we also have included this in as a reference cohort. So there is also reference samples for normal forebrain, normal hindbrain, brainstem, and so on, and also inflammatory tissues. So this can also pop up as a diagnosis. It could also say, this is inflammatory tissue, this is normal brain. And so the algorithm can basically recognize that. And the other thing that we are using is then whenever tumors have copy number aberrations, you can basically assess the tumor purity based on that, right? Because if you have an amplitude that would indicate 100% tumor cell purity, you can basically see whether if you have a single copy number gain, if this is like only whatever 0.3 instead of 0.5 in terms of amplitude, then you can assess that the tumor cell content in this sample is lower than 100%. So whenever the algorithm recognizes that there's a very low altitude of the copy number aberrations, it would also give you a warning and say, I don't really know whether this is a representative sample because it seems to have a relatively low tumor cell content. But on the other hand, for instance, you can also, we can also now start using DNA methylation analysis for CSF, so circulating DNA from the CSF, where you basically can also, in many cases, quite reliably detect the right tumor type, even without cells, right? You are just using the circulating DNA that is shed off from the tumor.
I have a question for you, pathologist, maybe because one of our collaborators from Sidra Medicine, Qatar, they suggested, for example, that they use like a sandwich technique for the biopsy, that when they like choose where to take the sample for the DNA methylation, that they do a sandwich before and after to make sure that there is a tumor tissue before the biopsy that we took for DNA methylation, and there is a tumor tissue afterwards. For the consortium, of course, we did not mandate this, and I don't know how much that would be demanding in the lab, but maybe this was one of the suggestions that their pathologists and technicians and scientists suggested that they will do in their institution, but you don't need to, of course. It depends on your practice.
Ms. Melrika?
Actually, here we do not do methylation tests yet. Yes, and yeah, it is true for some tests in pathology. We do have to determine the right areas, yeah. Especially for the tumor, we have to decide where the tumor areas is, and we have to exclude all the possible contaminants area that Professor Stefan already said, that necrotic area, inflammatory, non-tumorous area. So we have to make sure that the material that we get is from the tumorous and viable tumorous area. Yeah. Maybe so. Thank you.
To follow up on our discussion and what we hope, how we can collaborate using our existing infrastructure. What equipment that we have, and then we work together so that this kind of capability is we can do it here. Yeah.
Yeah, one part of the project is also to explore the different methods, and the other method that we want to basically explore is the nanopore based. So I think that you would be a very good partner side to also explore that, because you're already equipped with the sequencer and have experience running analysis on it. So that is definitely also planned to be part of this collaboration. And so maybe we can just get you in touch with Ariba Patel and Felix Sam, who are the two people in Heidelberg who are actually leading this. And then you can get started. Yeah. Sorry? Well, this is not on brain tumors, right? Your data is from other tumor sites, but
It's from nasopharynx.
yeah.
That's the brain.
So we just have that equipment around 4 to 5 months. Okay. So we are getting used to sequence.
Very good. Yeah.
Yeah.
Yeah, but well, it's great that you.
But the most confusing part is the bioinformatics.
So we also have Prakash here. Yes.
We just tried to do it, and we just bought the nanopore because they said that for the methylation is easier. We can do direct, right, with the nanopore compared with the Illumina. But there in the faculty, there are also people doing with the Illumina.
Yeah, we have had a meeting with them on Friday. They have an XSeq 550, which is also able to read out the arrays. So maybe we thought that we can arrange somehow with them that they can also basically run the methylation testing there. But at the same time, I think it's useful for you to also try to explore or to utilize your infrastructure to basically get the nanopore testing.
Yeah. The problem with us is with the bioinformatics, right? So he is the one who did it by himself.
Yeah, but I mean that's the advantage here, that the bioinformatics, you don't need any bioinformatics. You're just uploading the data and then you get your result back.
Yeah.
And that's at the moment less standardized with the nanopore, and we are also working on this to be more standardized, that you basically don't need a bioinformatician anymore to run it, but rather to upload your data, then get the result back.
Maybe another thing that we have to work further about, if we want to do the collaboration, of course we want to do the collaboration and we support to do it. About the agreement, there is some agreement about biomaterial.
Yes.
What? Biomaterial.
MTA.
Huh?
Material transfer agreement.
Yeah, but this one is not biomaterial, right? This one is the data from the biomaterials. I don't know. Maybe we have to ask somebody about this. Yeah. From our side, I mean. Yeah.
Yes, this is why we had sent the draft of the collaboration agreement a while ago for your legal people or whoever is in charge of that to review it. So I think it's basically, it has two aspects. One of them is basically data, which typically is much easier than samples to get transferred. And then there is also the question of for selected patients, whether if there is some request to do more deep analysis, more sequencing, also to also send material. But this is not the dependent point here. How to proceed with the collaboration. So I think that we can take that step by step.
We have to check from our side, because why there is a regulation because of the data, right? Data that come from the biomaterial tissue. So now we don't know, because what we do is the whole genome, right? Maybe if it is not the whole genome, it doesn't matter.
Well, here at least I don't have any idea about data protection in Indonesia, but in Germany and in the EU, this type of data is much easier to handle in terms of data sharing than genome sequencing data, because it's much more difficult to identify an individual based on methylation data than based on genome sequencing data. So I would hope that it's also easier, maybe.
Yeah, it is more targeted. Not the whole.
Exactly.
So another possibility is you develop the workflow, bioinformatic workflow, or instead of running in over there, we can also run it locally. I mean, we just install that software, we run it locally, and then we can do the sharing at the very end of the output. Yeah, the result.
Yeah, that's basically what we also think is going to be possible. I think as I said, for the methylation data, it's really not difficult because it's much less sensitive data than genome sequencing.
We have promethean nano.
From 1C
Also,
because they have an integrated GPU unit.
yeah,
And so, and as far as I can tell, they might be able to set it remotely, so we can connect you with
Okay.
them. Yeah, but what about the consumables? Like, would you be concerned about the cost of running it if you have the software, or you have some sort of funding to?
we have to find the grant. Yeah.
Yeah.
So we have the equipment. Software is no problem. I mean, the computer is the computing power is good enough, so we can run the analysis here with your software. The consumable we have to apply for grant so that we can do it. Yeah. Yeah. So the pricing is unfair. So the price in Europe is much lower than one.
That's the same with Illumina. We have also learned that many of the partner countries in our consortium now, they have much higher consumable prices than we would have in Europe.
So globally, it's around $900 for one promethean flow cell capable of 1,000 around 1,000 in US dollar.
Yeah.
And then here is around double.
Double
price.
Yeah, because of they are not selling directly; they sell it through
distribution.
And there is also some protocols now to basically wash the flow cells and reuse them. Have you tried that?
Yeah. But what we did is whole genome sequencing. So we use the whole flow cell to get the maximum data for one sample.
No, but wash it afterwards and
We
reuse it.
wash it, but the pores drop. So the flow cell up to 72 hours is not, even we wash it, it's not good anymore.
No, but we have, I mean, some colleagues, I think mainly in Switzerland, they have basically, they claim that they can use it 3 or 4 times. Yeah.
Perhaps they are not use up the pores yet.
Possible, yeah.
Okay, thank you so much from panelists. If there's any additional question from the audience here, because I didn't see any questions. Anyone? Yes. More younger.
I think I can remember 1 or 2 by the year. No, That's exactly the point that I try to make. That is that really we cannot understand cancer without looking into different populations, because there will be differences that are quite dramatic. When we had first looked at data, the first data from Jordan, that these mismatch repair associated high-grade gliomas are like 70% of all pediatric high-grade gliomas in Jordan, and in Germany, 3%. So it's really very different.
And also about the commonly pediatric cancer, Prof. This is very different in Indonesia because in other countries the brain tumor is second common the childhood cancer, but in here retinoblastoma is second commonly cancer, and then brain tumor is in top 10, but it's the number 10. Is that it's different? And then
Underdiagnosing it? Are children dying before reaching the hospital?
maybe, but for retinoblastoma is always number.
Well, I think
number
retinoblastoma is probably because it's hereditary then, right? And
But
it's,
we haven't seen the hereditary
no?
from
You don't have a higher rate of hereditary than in Europe?
yeah, usually from just from the history taking.
Yeah.
Usually the patient is if we ask about the
History.
the probability of the hereditary is the no family with this disease.
Okay.
Yes,
Yeah,
it's very
many of
interesting.
them are de novo, but still they are germline mutations.
But mostly unilateral retinoblastoma, not bilateral.
Yeah, maybe you're right. It's basically because they are being recognized relatively easily.
Course. And maybe for the registration, pediatric cancer registration is the most important thing to analyze everything. And so, because if we talk about the brain tumor, it consists of a multidisciplinary doctors, then clinicians, then maybe we need to have the complete or collaboration between multidisciplinary clinicians so that we can have maybe the total amount of the patient of brain tumor will be increased if we gather all the data from other departments, something like that. Because 1 year after I joined the fellowship of St. Jude, and I gather all the brain tumor, and the total number of the brain tumor registry is tripled by just before I joined the fellowship. So that's why the important thing is to do the registration together. Okay. If there's no additional questions or comments or anything, then maybe I can close this event. Then, so everyone, my professor, doctors, and colleague, as we near as the conclusion of this extraordinary event, I express my deepest appreciation to each of you for your unwavering dedication to advancing our understanding and treatment of pediatric brain tumors. Under the talk of the Professor Stefan Fischer, we can explore the innovative diagnostic therapies and also the collaborative effort to combat this brain tumor in our region and also in global for the most vulnerable population, which is the childhood cancer. And as we depart, let us carry forward to the knowledge, inspiration, and unity fostered here today, and together let us persist in our pursuit of excellence in research, compassionate patient care, and advocacy to improve outcomes in pediatric neuro-oncology. So thank you for everyone here, offline and online here, for your invaluable contribution and today's vital cause for us together here in Indonesia for combating the pediatric brain cancer especially. Thank you so much. Assalamualaikum warahmatullahi wabarakatuh.